High-risk pancreatic screening? Who needs it, and what does it involve? Hello, this evidence-based content is prepared by Sabor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been wondering about pancreatic cancer screening, particularly if you have a strong family history or known genetic condition, you're in the right place. I know when you hear the words pancreatic cancer, it can feel overwhelming and frightening. But here's the thing. For certain high-risk individuals, we now have screening programs that can detect early cancers and precursor lesions when they're potentially curable. Before we dive into who needs screening and how it works, let's establish what we're dealing with. Pancreatic cancer is one of the leading causes of cancer-related mortality worldwide. Most people diagnosed with pancreatic cancer have advanced disease that's already incurable. However, we now know that approximately 10 to 15% of pancreatic cancers are attributable to genetic causes. Here's where it gets particularly important. If you have Peutz-Jeghers syndrome or carry CDKN2A mutations, also called P16, you qualify for screening regardless of family history. These conditions carry such high risk that family history doesn't matter. The same goes for hereditary pancreatitis with a PRSS1 gene mutation. The clearest candidates for screening are individuals with specific genetic mutations. If you carry a BRCA2 mutation, that's breast cancer-associated gene 2, with at least one first-degree relative who has pancreatic cancer, you qualify for screening. These are your parents, siblings, or children. If you have at least 2 affected relatives of any degree, you're also eligible. Now, what does this mean in real terms? BRCA2 mutations increase your risk of pancreatic cancer 3.5 to 10-fold compared to the general population. For BRCA1, PALB2, that's partner and localizer of BRCA2, ATM gene mutations, ataxia telangiectasia mutated, and Lynch syndrome, you need at least one affected first-degree relative to qualify for screening. But here's something that might surprise you. You don't necessarily need to have an identified genetic mutation to qualify for screening. If you belong to a family with what we call familial pancreatic cancer, you may still be eligible. This is defined as having at least 2 first-degree relatives with pancreatic cancer who don't fit into a known genetic syndrome pattern. Now, what about if you have 3 or more relatives with pancreatic cancer on the same side of your family? You qualify. The timing of screening is crucial and depends on your specific situation. For individuals from familial pancreatic cancer families without a known genetic mutation, screening typically begins at age 50 to 55 or 10 years younger than the youngest family member diagnosed with pancreatic cancer, whichever comes first. For those with modestly increased risk mutations like ATM or PALB2, screening usually begins around age 45 to 50. For very high-risk individuals, those with CDKN2A mutations or hereditary pancreatitis with PRSS1 mutation, screening starts earlier at age 40. For Peutz-Jeghers syndrome, it begins at age 35. The 2 main imaging techniques used are endoscopic ultrasound (EUS) and MRI, with MRCP, that's magnetic resonance cholangiopancreatography. These aren't random choices. Research shows these methods detect significantly more pancreatic lesions than CT scans, while avoiding ionizing radiation. Here's what the data reveals. In a study of 225 high-risk individuals, EUS detected pancreatic lesions in 43% of people, MRI in 33%, but CT only in 11%. EUS involves passing a small ultrasound probe through your mouth into your stomach and small intestine, bringing it very close to your pancreas. Because there's minimal distance between the probe and your pancreas, we get remarkably detailed images. This procedure typically requires sedation, takes about 30 to 60 minutes, and is particularly good at detecting small solid lesions. The advantage? EUS can detect minute lesions, and also allows us to take tissue samples if we find something concerning. MRI provides complete imaging of your entire abdomen and pelvis, without sedation and without radiation. MRCP specifically images the fluid-filled pancreatic duct and its branches, helping us see cystic lesions and how they connect to the main pancreatic duct. This is superior to EUS for visualizing cystic lesions and their relationship to the duct system. Here's the typical screening strategy. For most patients with a normal baseline pancreas, we alternate between EUS and MRI/MRCP every year. This means you might have EUS one year, then MRI the next, giving you imaging every 12 months, but alternating the modality. For very high-risk individuals, particularly those with CDKN2A mutations or Peutz-Jeghers syndrome, we often recommend screening every 6 months, alternating EUS and MRI. Why more frequent screening? These individuals tend to develop more aggressive disease that progresses faster, and we need to catch it earlier. Now, let me give you context on why this frequency matters. In a study of 347 carriers of CDKN2A mutations followed for a median of 5.8 years, 36 cases of pancreatic cancer were diagnosed. When screening intervals decreased from every 12 months to every 6 months, there was a remarkable stage shift toward earlier disease. Of the 36 cancers found, 83% were considered resectable at diagnosis, with 12 being stage 1 tumors. Median survival after diagnosis was 26.8 months, far better than typical pancreatic cancer outcomes. This is the critical question. If you're worried about someone you love, you want to know whether this surveillance actually makes a difference. The evidence suggests it does, particularly for certain high-risk groups. In long-term follow-up studies from 3 European expert centers, screening detected pancreatic cancers had dramatically better outcomes than those found outside surveillance programs. Of 13 pancreatic cancers detected through screening, the 3-year survival rate was 73%, and median overall survival was 9.8 years. By contrast, 6 of 7 cancers diagnosed outside surveillance were stage 4 at diagnosis, with median survival of just 1.5 years. A systematic review of 16 pancreatic cancer screening studies showed that screening resulted in a higher curative resection rate, 60% versus 25% for non-screened individuals, and longer median survival time, 14.5 months versus just 4 months. If you're supporting someone through this, these numbers provide hope balanced with realism. Screening improves outcomes, but it's not a guarantee. First, assess your own risk. Sit down and map out your family history. Write down which relatives have had pancreatic cancer, at what age they were diagnosed, and which side of the family they're on. Include parents, siblings, children, aunts, uncles, and grandparents. Second, if you meet the criteria we've discussed, 2 or more first-degree relatives with pancreatic cancer, a known genetic syndrome, or 3 or more relatives on one side of the family, contact a genetic counselor. Most major cancer centers have genetic counseling services specifically for familial cancer risk. Come prepared with specific questions. Ask, based on my family history, do I meet the criteria for high-risk pancreatic cancer screening? If you have a known genetic syndrome, ask, what pancreatic cancer screening protocol do you recommend, and when should I start? Inquire about referral to a center with expertise in pancreatic cancer surveillance. These programs should have multidisciplinary teams, including gastroenterologists skilled in EUS, radiologists experienced in pancreatic MRI, and genetic counselors. If you're concerned about costs, ask about clinical research protocols. For those supporting a loved one, ask about signs that might indicate urgent evaluation. New-onset diabetes, in a high-risk individual, unexplained weight loss, persistent abdominal pain, or jaundice. New-onset diabetes in a high-risk person warrants urgent imaging within 2 weeks, as it may indicate an underlying pancreatic neoplasm. If you're in a high-risk screening program and develop new symptoms, persistent abdominal pain, unexplained weight loss, new-onset diabetes, or yellowing of your skin or eyes, contact your screening team immediately. These symptoms warrant urgent evaluation, not waiting until your next scheduled screening. If you discover you have 2 or more first-degree relatives with pancreatic cancer, and you're approaching or past the age of 40, seek genetic counseling now rather than waiting. The earlier you enter appropriate surveillance, the better. High-risk pancreatic cancer screening is available for individuals with specific genetic syndromes or strong family histories using alternating EUS and MRCP protocols that can detect early cancers when they're potentially curable. Your next step: map your family history this week and seek genetic counseling if you have 2 or more affected first-degree relatives. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.